Hello, this is Charles Epstein, host of the Catalyst podcast. Today I'm joined by Justine W. Welsh, MD. Dr. Welsh is Associate Professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine, where she is also a Vice Chair of Child, Adolescent, and Young Adult Services. She is also Director of Addiction Services for Emory Healthcare. And I guess when she has a moment of downtime, she is also medical director with the Addiction Alliance of Georgia. That's quite a lot of things to juggle, Justine.
Well, thank you so much for having me here today. I was incredibly excited that you invited me to do this. And yes, there's a few different hats that I wear, but I absolutely love every single one of them.
I am sure and you are joining me today from your office in Atlanta, Georgia, I assume.
Yes, yes, right across from the CDC.
And not only do I want to thank you for taking time out, I know you're battling with a bit of a cold, so I appreciate you soldiering through this, but we will make it through. I promise we will make it through.
Thank you for the hand holding.
Yes, yes. Again, Justine, really appreciate this. I want to discuss an important recent paper on which you were lead author titled Recommendations for Adolescent Substance Use, Treatment, and Policy. I should add that the paper's editors include Chestnut's Laura Passetti and Mark Godley. Justine, if you would describe in broad terms what the paper sets out to do. I know you did it as something of an update to the principles of adolescent substance use disorder treatment that the U.S. National Institute on Drug Abuse released in 2014.
And I do want to call out that this was certainly a group effort, and you mentioned a few of my co-authors, but it certainly took a team to pull this manuscript together. And really, what prompted it was a desire to build upon the original 2014 principles that had been published. And there was an original article by Ken Winters, Dr. Winters, who actually joined as part of the team for this revision to really update, given that there have been significant advancements in science coupled with a changing landscape of treatment options that just really necessitated a reassessment and an update of those core principles to ensure that they really remained relevant and that they were still an effective approach.
Yeah, well, obviously it's quite a span of time since these original principles were espoused and established. What were the biggest gaps or limitations in the original 2014 principles that prompted this update, that prompted you and the team of writers and editors to undertake this?
So I wouldn't say that there were any glaring gaps or limitations, but just given the significant amount of time since they were initially published, there were certainly updates to the field that we thought were important to highlight. So we ended up taking more of an approach that was focused on harm reduction with less emphasis on abstinence only based treatments and a bit less emphasis on the 12-step based treatments for youth, although there is some data to support their effectiveness. We also ended up adding a focus and a practice on continuing care and recovery monitoring, recognizing that recovery for many individuals is something that's more longitudinal and long term. And then we added in new information on behavioral interventions such as contingency management, which is really starting to take off with a stronger evidence base.
The questions I'm going to, ask really sort of teases some stuff out from the study from the paper. Can you explain how integrating care for co-occurring mental health disorders and substance use disorders improves treatment outcomes?
Well, I love this question because we really focused in on the paper on that key integration. So, substance use disorders and other mental health disorders or symptoms often interact and they can exacerbate one another, creating kind of this complex interplay in this cycle. And so, treating one condition without addressing the other often leads to a return of either psychiatric symptoms or substance use. And so when those services are integrated, individuals are more likely to engage in and adhere to treatment. They actually show up. It also can reduce the burden of navigating multiple providers and appointments, which can be overwhelming and sometimes an unnecessary or barrier. And then last but not least here, some of our younger patients aren't always treatment seeking, and this can certainly apply to some of our older patients as well. So it can be a struggle for caregivers to get them in the door in the first place. And so these integrated care settings offer a more supportive and understanding environment. And that also can help reduce the stigma associated with both the mental health components and substance use disorders.
Yeah, which sort of I think naturally leads to the next question. The paper highlights service accessibility as a key issue. And again, going to this idea of integration and the importance of integration, what are the most effective ways to integrate substance use treatment within the educational system?
That's a great question and something that we certainly called out as being worth further exploration. And so there have been some attempts to do this. And so we're learning as we go here, but integrating substance use treatment within the educational system can be really crucial for that early intervention and support. So schools are often a central community hub for young people, and it makes that an ideal setting for reaching those who might not otherwise be seeking help or seeking services. And so schools have the opportunity, as long as they're resourced, to seek additional training for their counselors in substance use assessment, intervention, and then potential for referrals. Educating school nurses to be equipped to identify signs of substance use and provide that initial support and potential intervention. And then there's also a number of growing programs that actually train students to become peer educators and provide that type of support to their classmates. So within the manuscript, it really was a call out that we need to be investing additional resources into supporting schools to be well equipped to be dealing and handling with substance related issues, as well as other
Mm.
general psychiatric concerns.
Let's assume you have these resources available within those educational environments. One engagement methodology referred to is having peers being equipped so they could reach out that may be more efficacious, that may sort of lower the barrier to engagement. What are some of the other barriers to adolescent engagement with the resources, assuming that the resources are there?
Yeah, so certainly speaking from a clinical perspective, I would say one of the number one barriers is there's a lack of perceived need. So adolescents often don't recognize the severity of their substance use problem or believe that they need treatment or are treatment seeking on their own. So often it's about engaging that family system while working within that therapeutic alliance, and increasing that internal motivation for that adolescent to identify benefits from treatment or identify benefits from improved family relations or being able to function more effectively at school. So something that we do, and I kind of highlighted this, that we included it in this revised manuscript, is contingency management. And so my clinic does a lot of contingency management, which is a behavioral intervention that uses reinforcers for performing or meeting a target behavior. And we can actually help shift the dynamic between parent or caregiver and adolescent by having them create a behavior plan, essentially, that uses reinforcers for different different target behaviors. And that might be something like attending sessions, so actually showing up to treatment, or having negative urine drug screens, so reducing or not using substances. And the trick really is to be finding something that's reinforcing, reproducible, and escalated, and can be provided often by the family in the context of that treatment plan. And my clinic helps families to set up what are these different plans and the specifics within, because it needs to be tailored to that family. And we do things from earning back lost privileges. So every time you have a urine drug screen that has a lower THC or cannabis level, you're getting more and more privileges back on an
Mm.
escalating level. And it just shifts the dynamic from often a punitive negative one to the family is providing incentives and reinforcers and a more positive environment for not using. So going to those pro-social behaviors. So it's a lot of fun to be able to work with families and to tailor these plans and see that dynamic shift in real time. So that's just one example of ways that we overcome some of the um, eh, issues that we often identify with internal motivation for treatment.
Yeah, makes a lot of sense. We just talked about in a previous podcast a study on that very topic about how young adults at the age of 25, I think it's their prefrontal cortex is still under development, and they're more susceptible to external motivators, and of course that changes as one gets older, and obviously the implications for that to some extent are what you're talking about. Um, Justine, CBIRT is mentioned as an important screening and intervention tool. Now, not every listener of Catalyst Podcast is hip to the lingo, as they say. So, if you would maybe describe what we mean when we refer to CBIRT and how effective has it been in adolescent populations? And in your view, or what you've seen, or what this study reveals, what improvements could be made?
So that the acronym here, we call it SBIRT. And so that stands for screening, brief intervention, and referral to treatment. And studies have demonstrated that SBIRT can successfully identify adolescents who are engaging in risky substance use. And brief intervention, so we've got the screening component. First step is identifying them. Then the next one is the brief intervention. And so brief interventions have been shown to be effective in reducing substance use among adolescents, including those who've not yet developed a substance use disorder. And brief interventions are exactly what they sound like very short, time limited, sometimes even 2 to 3 minute interventions using motivational interviewing to provide personalized feedback about substance use and do it in a very safe, non confrontational framework. And just that in itself can be enough to shift the dynamics in the relationship with substances. And then the referral to treatment is identifying who are those that meet the threshold in which they need additional services. And so, right now, within the field of adolescent addiction, we do need more research to determine the long term effectiveness of SBIRT. So, the screening, the brief intervention, and then referring to services if indicated in addressing substance use and substance use disorders over that kind of longitudinal time frame. I'd still say that there's likely room for improvement in some of these models by incorporating more motivational interviewing techniques that are sensitive to an adolescent's perceived perspectives and their values, making sure they're developmentally appropriate. And I'd also like to be seeing some more technology-based interventions that
I
are,
was just going to ask you that. I'm glad
yeah,
yes.
able to engage and be more accessible to adolescents, particularly from a confidentiality standpoint, where they may not necessarily be wanting their parents to even know that they're undergoing screening for substance use and what their responses or answers would be. And I think we need to do a better job of consistently implementing and integrating these approaches to screening and responding to substance use within the services that adolescents are already mentioning. So we talked about or already accessing. So we already mentioned schools. Schools are the perfect place for SBIRT models, school-based health centers, youth community programs, anywhere that you interface with adolescents where you have that opportunity to provide the early intervention.
Yeah, it's interesting because one of the through lines in all the conversations I have on this podcast is, the importance of delivery and solving problems of delivery into areas that are hard, perhaps they're rural areas or wherever they happen to be. And this idea of bringing services to where people live. And the fact is that a lot of adolescents live online,
Yeah,
and they're accustomed to using tech tools to sort things out. So it obviously makes sense to use that as a modality or to use that as a mode of interaction,
absolutely.
you know. You touched on harm reduction at the outset. I know that these kinds of services remain controversial in some areas. What evidence supports increasing funding for harm reduction in adolescents' substance use treatment?
Yeah, so harm reduction has a very broad definition. And so the definition that we are really using in this manuscript is that harm reduction is a set of practical strategies and ideas that are aimed at reducing the negative consequences associated with substance use. And so this can be a harm reduction model where you're not mandating abstinence, but you're meeting a person where they're at and helping them work towards reducing substance use, reducing the negative adverse consequences or high risk behaviors associated with their substance use. Or it could be reducing their risk of, say, overdosing by making sure that they have accessibility to naloxone, which is the overdose reversal agent, which is often delivered intranasally. So some people do worry that harm reduction approaches enable or encourage substance use, but research has shown that harm reduction services do not increase substance use. And this holds true across the board for the different age groups. And harm reduction approaches are often more accepting, non judgmental, and they can help engage adolescents who are reluctant to seek that traditional treatment,
Right.
especially the mandated abstinence only interventions. And so, from the manuscript's perspective, we need more research on harm reduction, how to make sure that that's developmentally tailored to reaching adolescents. Um, but we're also encouraging of employing harm reduction approaches and strategies within this population, given how much we know from the adult literature.
Yeah. No, that makes sense. You already touched on the importance of family involvement, but we got there through some other question. I think it's a sufficiently important element. I'm assuming you agree. Um, are there any other effective ways to engage families in this process in adolescent substance use treatment? Any other additional things you want to touch on?
Yeah, so uh, we always try to engage families wherever we can. And it's important to recognize that a family system's needs are often unique and very individualized. And so the first step is really just conducting a thorough evaluation and assessment to understand the family's strengths, their needs, any specific challenges they may have. I mean, that might even be barriers to transportation to getting to clinic. So having to modify the treatment plan around that. And then the intervention should also be really tailored to the family's cultural backgrounds and beliefs. And so asking questions to get a better understanding and sense. And then the treatment setting should always be safe and non-judgmental. And so I do remind myself that parents and caregivers are often scared and they're really worried about their child or their loved one, and they're doing the best they can with the resources and the tools in which they're equipped. And something else to keep in mind is that given the genetic risk of substance use disorders, families may also be struggling with their own substance use. So we really try to engage the entire family, make sure everyone is getting screened for substance use, for co-occurring psychiatric conditions or disorders, and then providing treatment and support to the entire family system as indicated. So it's less
Yeah.
about the individual patient, it's about the family system and the environment in which they live. and making sure that we're providing all of the services for the entire thing.
Right. I think one of the most sensitive elements in all this, and this comes from a perspective of a child of school teachers who are always talking about how they had to finesse conversations with parents who didn't really want to hear that Junior was anything less than perfect. So, in the world of substance use, where you may have people who themselves are not aware that they're crossing a line, their behaviors and so on and so forth, let alone their family. They keep it well hidden from their family. So sometimes it seems to me, yes, you have to be culturally sensitive, but also the way a parent might respond to an authority of somebody from school even broaching this subject. How dare you? I mean, it seems to me a very, very delicate issue that must come up time and again.
Absolutely.
I'm going to ask you one last question, Justine. And again, I really appreciate you soldiering through this. I know it's been a little bit of a struggle, but you've been great.
My
So
voice
thank
did
you.
hold up, so I'm glad we're
Yes,
getting
yes,
that.
I know we're on thin ice. But last question. If you could make one policy change today that would have the biggest impact on adolescent substance use treatment, what would it be and why?
You save the zingers, don't
I
you?
did. I
Not
did.
an easy
I
question.
did. I
I only
did.
get one.
Yeah, only one.
Only
I
one.
mean, you know what? I will give you two just
Okay.
as a bonus for again soldiering through.
Well, so I would say that the earlier you identify youth who are struggling with substance use, with mental health diagnoses or symptoms, even if they don't meet threshold for a diagnosis yet, I would invest in early identification because if you don't know what's happening, how are you going to provide intervention? And adolescence is such a critical period for brain development. And that early identification of substance use and mental health disorders allows for more timely intervention and then ultimately preventing an escalation of symptoms and some of those long term consequences that we know are associated with substance use and other psychiatric disorders and symptoms, including things like suicide risk. And so, if you would invest, and I would love to see investments across the continuum, but
Sure.
if you had to choose one, I would really invest in that early identification, being able to appropriately screen for problems before they begin to develop into the actual use disorders, et cetera, so that you can then intervene early.
I'm going to give you the option of citing a second thing if you want to risk talking for another couple minutes and putting your voice or sacrificing your voice for the cause.
I get a second policy change.
You do.
Well, I would honestly be investing in school-based services, school-based mental health services as well as substance-related services because you've got to meet the kids where they're at.
Right.
And many times they are not in a mental health clinic. They are in our school systems. And I think we need to better equip our schools to be responding to what is truly a mental health crisis in youth. And that can come in so many different ways from training and education for teachers, nurses, school administration, to also creating frameworks so that when students are identified as having some type of psychiatric related concern, that they have somewhere to go for a true clinical evaluation and assessment because teachers are already overburdened and they
Mhm.
don't always have the time or the training or experience to be able to do that. So
Yeah.
again, early identification, but then also providing those resources on the back end to actually be doing something with it once it's identified.
Yeah. Yeah. No, excellent. Excellent. And again, I recommend the paper that you involved in writing, organizing, titled Recommendations for Adolescent Substance Use treatment and policy. Justine, I really appreciate spending the time with me today and again, working through your cold, which I assume it is.
Yes.
Okay. No, I really do appreciate this. It's a great conversation. I was looking forward to it. Thank you.
Thank you for having me, Charles, and for tolerating me as I'm sipping on my warm liquids here. But I appreciate you and thank you for taking the time to focus on what I consider to be such an important topic.
Oh, indeed, indeed. Today I spoke with Justine W. Welsh, MD. Dr. Welsh is Associate Professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine, where she is also Vice Chair of Child, Adolescent, and Young Adult Services. She's also Director, Addiction Services for Emory Healthcare. And she's also, I should mention, Medical Director with the Addiction Alliance of Georgia. Justine joined me today from her office in Atlanta, Georgia. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.